Good morning. Good morning. On behalf of Inertis, I would like to welcome you all and good evening to those on the other side of the world. Today we have Dr. Nishi Joshi. Dr. Joshi is our distinguished speaker today. She is the lead transplant psychiatrist at Northwell Health, providing specialized psychiatric care for the heart, lung, liver, and kidney transplant patients. She's also a Consult-Liaison uh, psychiatrist and an assistant professor at the Zucker School of Medicine at Hofstra, Northwell. Dr. Joshi is board certified in both clinical psychiatry and Consult-Liaison psychiatry by the American Board of Psychiatry and Neurology. Dr. Joshi completed her medical education at St. George's University School of Medicine in Grenada. She pursued her residency at the University of South Dakota Sanford School of Medicine and further honed her expertise through a fellowship at the Donald and Barbara Zucker School of Medicine. Her work focuses on the critical intersection of mental health and organ transplantation, ensuring comprehensive care of patients facing complex medical and psychological challenges. With that introduction, I will hand it over to Dr. Joshi, who's going to talk today on psychosocial care in liver transplant candidates. Dr. Joshi, over to you.
Thank you, Dr. Sanford, for the warm welcome, and thank you for involving me and inviting me to speak on this platform. It's an honor. So without further ado, we're going to speak about kind of psychosocial care in liver transplant candidates. This is very similar to all the other organ systems. There's just a slight different patient population that we kind of deal with, and I think that we see at our transplant center. So I have nothing to disclose. These are just some of the objectives that we'll be talking about today. The role of a transplant psychiatry is pretty niche to the Consult-Liaison world, and to better understand kind of what psychological distress our patients face, and this is kind of very prominent when we talk about kind of liver transplantation, and we see quite a high prevalence of this particular patient population, but alcohol use disorder and kind of how ethically challenging it can be in the context of liver transplantation. And we'll talk a little bit about the barriers and challenges. So, what is transplant psychiatry? It's like I said, it's very niche, and kind of how does this differ from your normal psychiatric evaluation of a patient that, is not necessarily being considered. We are, stewards to these organs. We have to be quite equitable. So how does this kind of field, or how did this field kind of form, and what is kind of the role of this transplant psychiatrist? So, these first and foremost, I think transplant psychiatrists are assessing, psychosocial clearances is what we term it, for pre-transplant these patients to see if they have any, overt psychiatric needs that may pose as a barrier to listing. So rather than overt gatekeeping and kind of listing categories or things that would bar this patient from receiving a transplant, it's kind of seeing if there's any, risk factors that can be addressed, and so this patient is optimized rather for transplantation. It helps to optimize the patient prior to transplant. It's very difficult post-transplant if these psychiatric needs have not been addressed. It differs from your traditional evaluation as a psychiatrist, as I noted, because there's this level of kind of confidentiality that you can't really guarantee the patient and or the family member, just because you are still serving as a consultant for the transplant team. And so it's so important to be pretty transparent, and there has to be a special emphasis placed on the delineation of the transplant related expectation, aftercare recommendations, working and collaborating with the transplant team, and kind of relaying this to the patient. But that's not to say that you will not advocate. You can still speak to the patient and tell them that you are, there to advocate and kind of optimize them for the best transplant outcomes from the psychosocial standpoint. But there definitely has to be a delineation and kind of, so the patient is not going in expecting that whatever they're disclosing to you is completely confidential. There's also, this is the most important part of our evaluation, and we have very limited time to kind of capture and grasp this patient's understanding. Oftentimes it's very challenging with the cognitive status that they present in, but exploration of a patient's capacity to really understand, collaborate, and adhere to the proposed treatment. And oftentimes patients are just discovering that they need transplantation, or they have end-stage liver disease, or something is going on, that requires a higher level of care. So they might not have quite, have time to process it, and or health literacy can be a significant barrier. So we have to kind of go and really provide them with the education. And if there's any, barriers, or if there's any lag or in their communication with the team, I think the consult-liaison psychiatrist or transplant psychiatrist kind of will liaise with the primary team and talk to them. So the biggest thing for patients is we have to assess coping skills, and you'll see why this is very crucial in the post-operative recovery phase. And we oftentimes have very limited snapshot of these patients, especially the ones that I see on the liver transplant side. Not many have been chronically followed, and so we're kind of piecing together this puzzle of who this patient is and how they've been coping thus far. Oftentimes, there's quite maladaptive coping mechanisms, and you'll see how this kind of can affect their post-operative outcomes as well. The baseline cognitive assessment I alluded to, most of these patients are not quite completely able to provide the most relevant history, or they're poor historian secondary to being quite, encephalopathic or not quite there when you're assessing them. So, but at baseline, it's important if there is some semblance of establishing where they are at. As post-operatively, we deal with, I'm sure as you're aware, ICU delirium. CNIs tend to have quite extensive neuropsychiatric side effects as well. And we gauge, the presence of social support. And this is, not even though it's last thing on our slide, I think this is something that we give precedence to at our institution, and I'm sure kind of throughout the transplant world. We rely very heavly on the presence of social support, and our social workers work very diligently to delineate this prior to transplantation, because it has, and it's been shown, literature has shown that this impacts kind of how well the patient will do post-operatively as well. So psychological timeline of organ transplantation, this is not, very particular, very in terms of liver transplantation. I think this kind of is pretty standard across all the organ systems. I see this with my heart, lung patients as well, but it's important to understand the psychological distress the patient experiences to better understand how we can tailor a treatment plan, or kind of target it or treat it preemptively if we can, so they have better outcomes. So in the pre-transplant period, most of the patients are now having this decline in function due to the severe deterioration in health. It depends on the chronicity of the disease, obviously, but it's this very acute adjustment reaction versus low persistent, like depressive disorder, where the patient has known that they're progressively declining. There's a lot of demoralization over loss of autonomy, and this kind of concept comes up even in the peri and post-transplant period. I've had patients that kind of struggle with this the most, being debilitated, now relying on family members. I've had patients tell me that they were the quote unquote breadwinners for their family, and now this role reversal has caused them significant distress. Fear of outcomes of end-stage disease while awaiting organ, this is kind of that fear of death. Most patients will kind of come to this realization and are quite distressed, tearful, remorseful on exam, especially if there were some detrimental activities or something that they feel that they have done to impact kind of this their condition. This is very important to kind of address early on, and kind of get the palliative care team involved, not for, saying that this is end of life treatment, but it's important for the patient and the family to adjust and come to, terms with what's going on. And palliative care often partners with psychiatry, and does an excellent job kind of providing the adequate support in this period, since the wait can be unknown at times. Peri-transplant, or what I call in the recovery phase, this is immediately they've been transplanted or they're recovering, they're adjusting to new medication side effects And they can be extensive. We have patients that are now experience mood symptoms that were not there. There's a lot of body changes. Body dysmorphia is one thing that we've seen, which is not spoken about a lot in this realm, but patients are struggling with these newfound side effects. Post-operative cognitive changes, I think I alluded to, and discomfort, pain-wise. I think there's a very idealistic perception of what transplant will do, and most of the patients in the pre-transplant period expect that once transplanted, everything will be perfect, meaning there's going to be no pain. They're not going to be as frail. They won't have to really put in any work, and everything will kind of change overnight. And so it's so important to kind of provide them with that adequate education in that pre-transplant period. There's that brief hopefulness, what would they call the quote unquote honeymoon period, where they feel, this is a new life, everything is going to be great, which unfortunately does not last very long. And my patients, they start to struggle with this subsequent anxiety and fear over rejection of the organ. They're worried about kind of what life will look like post-transplant. So, and then the post-transplant, psychological kind of distress that we see is more so, obviously in the acute setting, first year, acute graft rejection, recurrent hospitalizations, need for rehabilitation. In this particular subset of population, we're talking not only physical, but it could be mental health rehabilitation in terms of if there's a prominent substance use disorder that has induced this liver injury. There's also, adjustment to this new restrictive lifestyle. So it's most of the patients are like the ones that have gone in with this perception that everything is going to go back to what life was prior to them having this decline in function. It's not a realistic expectation, and so they don't understand why they have to come on a weekly basis for blood work, why everything is so restrictive, why they're on a plethora of medications. And late stage is more so after the year, and so you can see this kind of psychological distress doesn't really go away. It kind of follows them throughout kind of their post-transplant recovery too. And so I often tell my patients that, this is not a sprint. It's not, there's no end, like there's no finish line. It can be an ongoing kind of marathon, and there'll be good days and there's going to be bad days. The one thing that I do want to highlight is that at this stage there is a little bit of caregiver burden versus burnout, and this is why we rely very heavily on kind of vetting out the social support. We tend to see the poor outcomes kind of come hand in hand with the lack of social support, and patients' expectations that they're going to return to pre-morbid health, and ideally they would, but the recovery times can vary per patient. So I think it's very important to have both family and patient on board with this. So, sorry. So the psychological challenges, kind of in line with what I just discussed, pre-transplant, untreated psychiatric comorbidities, and I'll touch base on this the most. I think this is the area that it brings most kind of pause whenever talking about, this patient has, X, Y, and Z psychiatric comorbidities, what's going to happen. So when you actually have untreated psychiatric comorbidities, mood or affective disorders, your traditional bipolar disorder, major depressive disorder, anxiety disorders, combined with poor pre-transplant distress tolerance, you have the increased risk of post-transplant morbidity and mortality. And it makes sense, but there's multiple literature studies, especially with regard to depression, that have shown that when you combine this with patients' poor, or maladaptive coping, this is just a recipe for bad news. They have, liver transplant patients, this is pretty interesting, have a higher prevalence of adjustment disorders due to impact on body image, more than the other organs, which, this is, like I said, it's often kind of gleaned over and glossed over. And there's this excellent study by the transplant psychiatrist at Yale about kind of body image and how this kind of affects the post-operative quality of life in liver transplant patients. and their overall recovery. And it's so significant that sometimes it can even impact their ability to partake in physical rehabilitation, and kind of they almost isolate and don't want to do anything because they're expecting their the perception of what they think is the ideal kind of body image is not what happens post-transplant. So I found it pretty interesting that liver transplant patients actually have a higher prevalence of this as opposed to the other organ systems. Self-esteem and stigma further worsen due to sexual dysfunction. It's not as prominent in the liver population, but there is mild to moderate sexual dysfunction post-transplant, secondary to medications and kind of the changes that we see from the endocrine standpoint. But something that is also not kind of talked about and gleaned over, and it's something that patients tell me post-transplant what they're struggling with, and it kind of impacts their psychosocial functioning in terms of having relationships, right? So this is kind of well known to everybody. ICU admissions are linked to heightened stress response, leading to high incidence of post-traumatic stress disorder. Diagnoses post-transplantation, it can be as high as 46%. We have seen. So the prolonged ICU admission stays of patients should definitely be connected with psychiatry, as we see a high incidence of PTSD in this patient population. And then even patients without any premorbid or like pre-existing anxiety disorders, up to 35% of liver transplant patients have endorsed some form of anxiety post-operatively, which never existed prior to. So pre-existing behavioral conditions, this is very briefly, I'm just going to talk about this. I know vast majority of the lecture is going to be probably on alcohol and substance use disorder, but I know there's people feel very uncomfortable with psychotic disorders, and it's interesting, find that patients with schizophrenia or schizophrenia spectrum disorders, as I like to call them, schizoaffective, all this, there's no absolute contraindication to transplantation. Actually, multiple studies have kind of shown that the adherence rate to medications is quite equivalent to the general population, and so are the outcomes if the patient is engaged in psychiatric care, meaning if the patient's already connected to psychiatric care, has been compliant with that care. Vast majority of this non-compliance that people expect with this kind of this patient population of severe schizophrenia or psychotic disorders has to do more so with access to resources. We've seen, at least at our institution too, the patients that have these really severe psychotic disorders, even sometimes bipolar affective disorders, they have a lot of other stuff that's kind of contributing to their non-compliance too. So unstable support, housing, and kind of access to psychiatric care. If that kind of component is assessed or fixed, obviously, they have better chances, and it's kind of equivalent to the general population. And so, in terms of severity, psychotic disorders actually fare better than what I call like the depressive. And so, vast majority, I think, literature all across transplant psychiatry for organ systems, I think major depressive disorder or depression actually is probably the worst in terms of prognosis post-transplant. Anxiety disorders also are, less likely, but I think I'll get to that in a little bit. One thing to talk about for psychotic disorders, obviously, is if they have positive symptoms on exam, meaning if they're already actively hallucinating, probably a contraindication to transplant at that time. They should probably be treated. But we're talking more so like chronic stable psychotic disorders are not an absolute contraindication. Personality disorders, this is also, I feel like, sometimes overlooked because it's not an absolute contraindication. And remember, a personality disorder is defined by kind of this maladaptive, a cluster of traits that are quite maladaptive and make them more prone to like poor outcomes. These and every personality disorder is not made equal, so this is not a blanket statement for all personality disorders. This is only for certain disorders that may pose a higher risk for graft loss due to maladaptive coping mechanisms, poor distress tolerance, which severely impacted social functioning. So, for example, a patient with borderline personality disorder would may need active enrollment in a dialectical behavioral therapy, or it's a form of psychotherapy kind of specializing and patient developing these healthy coping mechanisms. Actually, it's borderline personality disorder. this has been replicated in multiple studies that it can show the splitting behavior, the mood, lability, instability, can obviously indicate poor prognosis and kind of higher cases of graft dysfunction and kind of loss because they just stop taking medications, negotiating care with the treatment team. Similar to that, I think antisocial personality disorder is something else that should be mentioned. Very, very stark, prominent kind of power dynamic between the patient and the treatment team, kind of always challenging the treatment team. Um, and so it basically impedes cooperation with providers or aftercare recommendations. And that brings, there's a huge correlation between patients that actually have antisocial personality disorder and substance use. And so that kind of brings us to the patient population that I think we see the most in kind of liver transplantation. And at least at our institution, I think we see a vast majority of patients, unfortunately, suffer with very severe alcohol use disorder. So, burden of alcohol use disorder, I'm sure you're well aware of this, and this is a little dated, and I apologize, but I think that's the statistic from 2016, but I think it's been relatively stable, if or the same, or if not a little bit more. I think we've seen an uptick in kind of this morbidity, or sorry, mortality and disability overall since COVID-19 pandemic. I think we've also seen an uptick in our patient population that are now presenting with very severe alcohol use disorder at a very early age, especially after the pandemic, because of the isolation and kind of every the psychological distress that it brought. So it is, like I said, it's a leading risk factor for premature mortality and disability amongst those aged 15 to 49, with a 10% mortality in this age group, and that's quite extensive. It accounts for about 7.1% or 2.2% of the global disease burden for males and females, respectively. So harmful alcohol intake. This is important to define for patients because oftentimes it's overlooked. As, in the United States, at least, there's this kind of culture of like drinking on daily, or maybe going to happy hours, and so a lot of the patients are quite flabbergasted when you tell them that this is actually you're actually consuming harmful amounts of alcohol. So it's more than two standard drinks in men and one standard drink in women in a day, and then obviously binge drinking is five standard drinks for men and more than four drinks in women for in a span of a 2 hour period. So it's very important that when we're discussing kind of alcohol use disorder with these patients, we're also talking to them that it is indeed a disease process, right? Any addiction or any substance use disorder is obviously, addiction is a disease. So it's not, in the most non-judgmental way, I kind of relay that it is a chronically remitting, relapsing kind of core. It has a chronically remitting, relapsing course rather, and so it's not something that overnight is going to change. Unfortunately, is something that is pretty difficult to treat. And patients will always tell you that, they can do it on their own. They had 3 months of sobriety before, they don't foresee any barriers, but, obviously, statistically speaking, that's not going to happen. There's always going to be a huge, huge risk of relapse. And you'll see why this is the case in terms of what the behavioral kind of structure of addiction is in terms of like what happens to the patients and the stages they go through, and it's pretty slow kind of recovery as well. So, it's important to kind of preach and kind of talk to the patient, and that alcohol associated liver disease is a disease of dual pathology, where with alcohol disorder being one kind of part of that pathology. Oftentimes patients disconnect that even if they have some insight that alcohol has induced liver disease, they will often focus on the liver aspect of it, but don't believe the alcohol use is a disorder in itself. It is one of the most common defined cause for both liver transplantation and listening indication for adults below 40 in the United States. Like I said, there's been a recent rise or since COVID-19, and we're seeing more and more younger patient population coming with this very severe kind of presentation now. So, psychiatry, this is, diagnostic and statistical manual kind of guide or our how we define alcohol use disorder. It looks kind of extensive, but it's very important in terms of classification of like the mild, moderate, and kind of symptom severity. And it's important to understand the level of kind of debility that occurs because of this. So because of that persistent desire of unsuccessful efforts to cut down, you're going about, kind of pursuing activities necessary to obtain alcohol is now impacting your social functioning. So that kind of differentiates a use disorder from kind of like this social alcohol, or, it could be hazardous alcohol use, but they might not meet full criteria for what we define in psychiatry as an alcohol use disorder. And so there's a significant failure to fulfill major role obligations at work or at home. And so these patients oftentimes continue to consume alcohol despite having having legal repercussions. We've had patients that have had number of DWIs or DUIs and or even court mandated treatment, and then so it's gotten to the point where they're no longer able to kind of rationalize their use and kind of understand the impact it's had on their relationships, their lives. It's particularly hazardous. So tolerance, they need more and more increased alcohol. And then withdrawal, I think everyone kind of knows this, but any hospitalizations, any tremulousness, and one thing that I like to kind of speak about is sometimes patients will say they're not withdrawing, and they'll say they've never had a withdrawal, and not that they're lying per se, but I don't think the good thing to ask is, okay, well, have you ever woken up in the middle of the night and felt a little anxious? And I've had patients that say, yeah, I just take a shot of alcohol. So I don't think if they don't ever have a period of sobriety or sustained sobriety, they might not have withdrawn. It sounds silly, but I have plenty of patients that tell me that they've never experienced any withdrawal, but they never really had a period of time where they stopped drinking until they probably came to the hospital. So oftentimes you have very like early morning awakenings, or in the middle of the night, they're consuming a lot of alcohol. So why is this kind of impact, and why is alcohol use kind of the main topic for today, or in terms of like how it poses a challenge in our particular patient population? So, we're seeing these patients in a setting of precipitous decline in their health, and a lot of them actually, this is the initial encounter in which they've discovered they actually have an alcohol use disorder, or they need treatment, and subsequently are now being consented for transplantation. It's very challenging to build rapport, with these patients, because this is kind of a mandated psychiatric evaluation, so it's oftentimes not very welcome. The patients are more likely to listen to our hepatology colleagues than psychiatry in this respect. But it's important that this observation is now made through a biopsychosocial lens, creation of this therapeutic alliance, and this very non-judgmental interview, and a matter of this is kind of what has led to your liver disease. Without adequate treatment of your alcohol use disorder, it's like putting a band-aid on it. And so that's how we kind of approach it, and in the most non-judgmental kind of fashion. And I know theoretically, there's a lot of countertransference sometimes amongst clinicians and kind of the patients that actually have no insight into kind of what has led to their dysfunction. So the other challenge is the cognitive deficits. As I mentioned, the hepatic encephalopathy. It's a very limited interview, and it's very difficult to gauge anyone's like insight or how well they're going to do in terms of their understanding of alcohol treatment, and if they're going to comply, if the patient is quite like nonverbal. Family will always try to advocate. We do rely on some collateral history, but family tends to skew the assessment in a more, rightfully so, they want to advocate for their patients in a positive fashion. So, it's very challenging, because going strictly solely off of the family's assessment oftentimes is not the most ideal. It'd be great if the patient is able to partake in some part of this evaluation. Again, with the comorbid psychiatric disorder, this does pose as a challenge, because a lot of these patients have never seen a psychiatrist or any form of kind of therapist prior to they are now not able to provide the most accurate history. And so you have a very brief time of kind of trying to figure out what this patient has endured, and while they're challenging with while they're kind of struggling with these cognitive deficits. So, you know, once again, I think depression, clinical depression, or what we define as major depressive disorder, is probably the worst in terms of psychiatric comorbidities and illness. It's shown a significance in predicting decreased survival, and there's numerous studies that have kind of showed this. The biggest one I think I outlined prospectively, it showed kind of a 66% survival rate for just mild depression, and then this kind of decreases even further to 43% for severe depression. Just a kind of quick take on opiate use disorder or opioid use disorder, because I know that that can also pose as a challenge. And as proven, if the patient is already kind of plugged in with medication-assisted therapy, we're talking about methadone, Suboxone, there are favorable outcomes. So it's not a complete, absolute contraindication to, although, the guidelines are subject to, each institution is pretty different and kind of what they will allow and not in terms of opiate use. But generally speaking, obviously, if they're not using IV drugs, they've been connected to services and compliant with their treatments, they do have favorable outcomes. Tobacco use disorder, this is also pretty subjective and subjective, and it kind of changes, actually, interestingly enough, per organ system too. But this is kind of one of those things that this was the only thing that kind of came up for post-liver transplant patient population. I don't know how significant this is in practice, because we kind of really heavily kind of want them to really stop the tobacco use in our cardiothoracic patients. But it's important to realize that these are all kind of forms of maladaptive coping too. So if they've had a use disorder, it's important that we are treating whatever underlying anxiety, depressive symptoms that they're trying to kind of treat with this use of substance. Okay, so this is kind of where why it's challenging to treat this particular patient population. This is the trans-theoretical model of change, and it kind of defines how addiction works, and kind of you might have seen this, but this is why it's very challenging to kind of change, as even though the arrows are showing that it's going progressively forward, it's actually more like a circle. It goes, you have a chance of kind of relapsing or kind of going back, even when you reach that maintenance phase. There's always a chance that you might kind of go backwards. So vast majority of our patients, when we see them, especially in the acute alcoholic hepatitis patient population, they're kind of living in that pre-contemplation stage. So pre-contemplation is they're in absolute denial about the severity of the consequences of their kind of actions. They have no thought of behavioral change. These are the patients that are telling you, I can quit anytime I want to. There's no negative consequences. I'm okay. I don't need any treatment for alcohol. Alcohol is not a problem, despite you seeing them in the setting of, a liver transplant evaluation. So this is kind of the most challenging state. And how can we get them from pre-contemplation to contemplation, and through obviously motivational interviewing and therapy. But sometimes we don't have this time. We don't have the patient is obviously severely debilitated. They're very sick. The mortality risk is high. So pre-contemplation is kind of that stage that we see vast majority of our patients kind of live in. So if they make it to contemplation, which I have seen, if a lot of time and kind of with progressive kind of with ongoing education. So contemplation is, they're more open to the idea of changing the behavior. They begin to contemplate kind of their substance use and the effects it's having on their life. However, they're still not ready to commit. And so to making the behavioral change, they're kind of thinking about it. So it's just these initial thoughts without change and without the intent to change. And, it's not until the actual like preparation and action stage where they're preparing to make that behavioral change. And in action, they actually start participating in like medical detoxification, attending kind of treatment groups, Alcoholic Anonymous or relapse prevention programs. And believe it or not, actually, the action stage actually poses the highest risk of relapse. So even though they've gone this far and they're finally at that action stage where they're making the steps to alter the behavior, vast majority of the relapses we've seen actually occur in the action stage. And it's kind of unfortunate, but that is kind of the nature of the disease process. And we see that oftentimes patients will go backwards. And so even with once they reach the maintenance stage, there's always going to be kind of this risk. And so it's important that this patient understands that, and kind of continues to work with the treatment team, especially in the post-op period. I think with the psychiatric providers with addiction psychiatry and or medicine to kind of remain in this sustained kind of remission phase. So maintenance is obviously they adapt to the behavioral changes and then they maintain the habits, and then the person will kind of solidify the habits, the good kind of coping mechanisms that they have obtained in their action stage in this maintenance stage. So as you can see, it's quite challenging for the patient to kind of go through this, and expectation of them to do this kind of overnight, it's not going to happen. And so what can we do kind of to better help facilitate this? And I'll get to that, I think, towards the end. So pre and post transplant sobriety, I think this is kind of the biggest topic and of debate in terms of like what can we do to predict definitively that this patient will not drink again? Can you tell me definitively, like 100%, that this patient will not? And unfortunately, there are no tools, even though we'll go into some of the existing kind of psychometric measures or what we utilize in conjunction with the psychiatric evaluation. So there's actually no specific number of months of sobriety that can predict development of sustained remission. And I think that's important to understand because for a very long time there was this kind of belief that 6 months of sobriety would indicate that this patient would remain in remission or sustained remission. Unfortunately, that 6-month rule was not, it was not clinically correlated. I know vast majority of the transplant institutions worldwide kind of adapted the 6 months rule. And the goal was that, if the patient is able to maintain sobriety for 6 months, there's a chance that they will not drink again or they will recover with regard to whatever is causing their disease, right? So that unfortunately was never corroborated or, there's not much like data supporting that 6 months is the golden number. There's actually no golden number. So that is something that's important to understand as well. And so patients with acute alcoholic hepatitis, they're usually ineligible or refractory use, if they have failed kind of the glucocorticoids, the corticosteroids, it poses a challenge. They don't have 6 months. Even if we did this arbitrary kind of gave them a number, they might not necessarily have the 6 months. Mortality is imminent. They will pass away prior to them reaching this kind of goal. And so it's important to kind of come to terms with that too, and understand that there's no right number. So what we can do is kind of risk stratify and kind of help map out what can somehow predict some risks of remission versus relapsing. And there's a prospective study that assessed time to relapse in alcohol consumption post liver transplant and found like the number of months that the patient was sober was the strongest independent factor for prediction. So not a specific number, but the number as in the longer period of sobriety, which would make sense, was actually probably the strongest independent factor, but there was no golden magic number. It's important to identify and stratify the known risk factors and so we can aid in the development of an actionable treatment plan. I think that's the biggest thing. What can we do? Because it could feel like a helpless or hopeless situation. Candidates with poor insight, I mean, this is also pretty, it makes sense, but candidates with poor insight into a need for alcohol use treatment usually pose a greater risk for relapse in comparison to those who even partake in what we call relapse prevention programs in the pre or post-transplant period. So, ideally, we would want patients to kind of enroll in a relapse prevention program or treatment for alcohol use prior to transplantation. If obviously, it's not possible due to what's going on medically. Even patients that have enrolled in post-transplant kind of relapse prevention program actually have shown statistically that they do much better in terms of in comparison to these patients who might even have, I have patients that have, I've been sober for 4 or 5 months, but I don't have an alcohol use disorder. So those patients actually, literature has shown they actually do far worse. They're actually at a higher risk of relapse, even with that longer period of sobriety, because they lack the insight versus the patient who might not have that kind of period of sobriety, but the insight is there. And that kind of ties into that stages of change model, right? That patient that might have been sober for 5 months might not necessarily be in that pre-contemplative, contemplative. They're going to just stay in that kind of phase and they will not progress because they don't think it's a problem. Okay. So when I talk about risk factors and kind of actionable treatment plan, this is kind of what we target at our institution, and this is what literature has shown is kind of the risk factors known for alcohol relapse. Like I said, there is no measure with high fidelity that there's going to be absolutely no relapse, but these are the risk factors that have been identified in literature as being something that should be, considered when we're evaluating the patient. So I talked about the first one. The younger age of the patient, believe it or not, it's worse prognosis, especially if they have severe alcohol use disorder. Relatives with substance use disorder, there's a huge genetic component to most substance use disorders, and we'll see a lot of our patients with alcohol use, opiate use disorder, actually have family members that have experienced that too. So that actually does pose kind of a risk factor as well. History of treatment noncompliance, I mean, past behavior is usually predictive of future behavior. If patients were pretty non-compliant, despite learning about kind of the complications and the impact this has had on their health, we're talking about patients that were provided with resources on numerous occasions and kind of still were non-compliant, even with their medical treatment. I mean, poor prognosis. Shorter duration of sobriety, I just kind of alluded to that and I kind of mentioned that. Prior unsuccessful attempts for treatment, if they've had numerous attempts at relapse prevention programs and they have just subsequently relapsed, they actually will not do as well in terms of post-transplant. I think there's a huge chance that they might relapse, even if there was no transplant. I think it's just generally known that if you failed treatment, and we're talking about MAT, medication-assisted therapy, and psychotherapy, they're not going to do as well as the other candidates. And then poor social support. So these are kind of psychometric measures, or sorry, clinician scales that we use. Psychiatry lives in the gray, but that doesn't really work very well when we're trying to understand. And so this is kind of nice. These scales, this is certainly not a comprehensive list, but especially SIPAD and SALT, the top two, it gives a nice numerical kind of assessment and helps kind of tidy up the psychosocial assessment because it takes into account, both social barriers, in terms of where they live. SIPAD was created by Dr. Maldonado, the Stanford Integrated Psychosocial Assessment Tool for transplant. It helps to kind of assess the patient's knowledge, motivation, comorbid psychiatric symptoms, lifestyle factors and modifications, social support. It kind of summarizes all of the above and kind of classifies the patient as excellent, good, minimally acceptable, high risk candidate. And so we often use this in conjunction to a psychiatric evaluation and all other kind of things. None of these tools should be used as the end all be all to defining if the patient is kind of the most ideal candidate, but it is something that helps just because it takes all the kind of aspects and does it summarizes it for the transplant kind of committee to understand. It also has pretty good inter-rater reliability, so we've oftentimes have had our social work colleagues to kind of help out with that. The SALT score was created, sustained alcohol use post-transplant, to assess probability of brief and sustained alcohol relapses in patients undergoing transplant evaluations. And so these are what they call SLIPs or kind of brief relapses post transplant. And so it's often sometimes used in conjunction Audit, cage, those are kind of used in kind of primary care settings. But once again, all of these are kind of just numerical kind of psychometric measures, something that I think we can kind of define. The other thing to understand is since tools such as SciPat do take into account like capacity and how well the patient understands the severity of their disease process as well as transplant, it can change, their understanding can change. It does take into account cognitive status because it incorporates what we the MoCA or the Mantra Cognitive Assessment, and it does take into account if the patient was encephalopathic. So it can definitely change. So it's not kind of a static standard score that just lives with this patient. If their insight improves, the score will improve too. It's a great kind of compass to a kind of a tailor our treatment regimen, but certainly should not be the only tool or only thing that's being used. And then the other ones are shown below. So kind of in conjunction with that, what we do is kind of screening and maintenance, and I'm sure we're well aware of this. At the top are, you can use the pre-trans, they're used, the tools are used in the pre-transplant period. PHQ-9 and GAD-7 are quick questionnaires that psychiatry uses for depression and generalized anxiety disorder, respectively. We also heavily depend on kind of urine or sorry toxicology screens as well, and as much as we want to continue that rapport with the patients, we like to standardize and tell the treatment and kind of the screening process and tell the patients that you will be serially screened while you're waiting for transplantation. And so the top one, PEth, the phosphatidylethanol, I think is kind of the what in our institution is our gold standard. It's a minor metabolite of ethanol, and it's a phospholipid that's synthesized, excuse me, and stored in membranes of red blood cells, and can be measured in whole blood samples. And the unique feature is that on the RBCs, on red blood cells, there's a lack of critical catabolic enzyme, so it kind of stays on these cells as opposed to the other ones. And the elimination half-life of PEth is usually 4 to 7 days. And it gives us a nice kind of window of detection of alcohol use up to 28 days. And so PEth kind of differentiates a little bit from CDT in that it can kind of pick up like moderate alcohol use. It doesn't have to be severe, but it can pick up a nice snapshot of moderate alcohol use. In terms of sensitivity and specificity, PEth has up to close to like 100% specificity and pretty high sensitivity for these individuals who consume moderate to heavy amounts of alcohol. And I think CDT does not have, it's not as sensitive. ETG or ethyl glucuronide is also another kind of measure. And it can be present in the urine up to 48 hours and sometimes 72 hours, but we really need that nice time frame, the 28 duration. One caveat to use of PEth acutely is obviously if the patient drinks just yesterday without any prior alcohol use, it might not necessarily come back positive right away. And so you do need to wait a little for the PEth positivity. But it helps kind of guide in terms of and monitor the patients. And you know, patients are not pretty forthcoming, but we also don't want to use it as just a punitive measure. It's more to tailor our treatment regimen. If the patient is truly struggling and continues to have positive PETs, what else can we do to help this patient achieve sobriety? And then post-transplant, obviously the depression and anxiety screen is there. And you can obtain PEth values to see if the patient is compliant. That is very dependent on kind of where the patient is in terms of their postoperative recovery and how well they've been in terms of compliance with care. Medication-assisted therapy. So I can't stress this slide enough. Unfortunately, it was like one of the last ones that I have, but I think it's so underutilized, at least in our field in psychiatry. I think there's a lot of kind of misinformation about use of these medications, especially in this particular patient population. I know Dr. Satapathy just led a very interesting talk at our institution about the use of naltrexone. I think there was a 2024 study that indicated, it's pretty relatively safe to use in both I think compensated and decompensated cirrhosis. I think he was discussing this with our fellows, but naltrexone is kind of the ideal medication for this, and it is an opioid receptor antagonist. So unfortunately, not ideal to use in the immediate postoperative period, just because our patients need analgesics, especially opioid with opioid properties, and so you don't want them to continuously withdraw if you're administering naltrexone, but in the past, I think there was a lot of concern that, it can cause this drug-induced liver injury, and at least in the world of psychiatry, that it's quite hepatotoxic. So, providers would often kind of steer away from the use of naltrexone. But I think we use it quite often in our institution, and we obviously when the patient is off of any opioids. But it reduces rewarding mechanism, and it provides this positive, the mechanism that which provides positive reinforcement of alcohol use. Acamprosate is also, kind of one of our first line medications, and it's an NMDA antagonist, and it targets cravings. It's quite nice because it is renally excreted. It is dosed 3 times a day, so sometimes compliance can be an issue. But other than that, it's pretty efficacious. I think naltrexone has more literature supporting its use in overt binge drinking, but acamprosate has better data supporting its efficacy if the patient has achieved even some sort of sobriety, some period of sobriety. Baclofen, a little less use, but this is the only one that had an off-label medication, RCT, for ALD treatment. Gabapentin is another one that we kind of use. It's very off-label as well. It's a modulator. We like gabapentin just because, it kind of aids with this possible comorbid anxiety disorder. There's a flavor that comes with alcohol-induced like anxiety, and gabapentin tends to target it. It's often also, I've seen in practice, kind of underdosed. So it also needs to be administered pretty much 3 times a day, and with a further dose adjustment. If the patients can tolerate it, also pretty renally excreted. Gabapentin in conjunction with naltrexone is something that I've seen in practice, and I think it's pretty helpful for these patients. One thing about the naltrexone is if compliance is an issue, it can kind of help, administering Vivitrol, which is the long-acting injectable, and it's a monthly kind of injection. So if they're able to tolerate the PO, it can be transitioned. I think the only caveat or the only barrier to that, at least in the United States, is it's quite expensive. So I think for, coverage is also, and accessibility can matter. Topiramate, we don't at our institution use this, but I know there's literature that says there's some benefit to it. Absolutely, we do not use disulfiram, severe hepatotoxicity. Also, in this post-COVID era where there's like hand sanitizer and everything, I've had patients with that have had reactions even to that when they're on antabuse or disulfiram. But it is a non-reversible inhibitor of aldehyde dehydrogenase. So so path forward, what does this mean? What does this all kind of mean in terms of what can we do to help these patients? So at the end of the day, it's kind of what a multifaceted approach, cognitive behavioral therapy, motivational enhancement therapy, lots of psychotherapy in conjunction with MAT use is probably the most efficacious. Medications alone will not be helpful. As you can see, the patients need to go through their stages of change, and that will not occur if they're not in any form of therapy. And this is why we kind of really push for patients to enroll in relapse prevention programs. And so the way the relapse prevention programs are structured here are, there's a psychiatrist on board, there's a psychologist or therapist, and there's not only group sessions, but one-on-one sessions. So the treatment is quite individualized and quite tailored to the patient's recovery process. If the patient has a comorbid psychiatric diagnosis, we refer them to dual diagnosis programs in which the psychiatrist will treat whatever, comorbid disorder existed that was probably fueling this ongoing alcohol use. We talked about the tools and kind of there's just 2 things in terms of like why there's so much mixed, the data is quite mixed on kind of if these tools are going to be able to predict if the patients will, I guess, do poorly after transplant versus if they're going to relapse or not. So, there's one retrospective analysis that shows that, post-transplant patients, when they compared three different models, the predictive modalities of value of all three modalities was pretty poor. So that's kind of disheartening. But then, there are subsequent studies that show that, the both SALT and SIPAT, especially over the score of 21 and SALT over the score of 7, was associated with alcohol relapse and resulted in harm to liver graft. So the other thing that we've actually noticed at our institution, and I will let Dr. Satpathy talk about it, but if we aggressively intervene based on their scores, we tend to kind of change the outcome in a positive way. And so that's kind of what we've used it, more like a compass and kind of to see what areas we need to target. And so we aggressively approach that either in the pre or the pre or post-operative period. And we're pretty aggressive in terms of, use of MAT and enrollment in relapse prevention programs. Also, we work and we partner with the community providers. We have actual transplant specific relapse prevention program groups. So a lot of the relapse prevention programs we refer our patients to actually specialize in kind of transplanted patients. And so it's patients appreciate that more because they feel that the treatment is more relevant for them rather than them kind of being in a kind of just a group of patients in different stages of recovery and kind of different disorders. Patients also, depending on where they are, I tell them they probably have some exposure to what we call Alcoholic Anonymous. And if there's a spiritual component to it, 12 steps of recovery. And a lot of my patients are not necessarily spiritual, so they assume that all relapse prevention programs are the same. And so it's important to kind of provide them with that education that that's not necessarily true. You could always do AA if you wanted to, but that's not equivalent to an RPP or what we're kind of recommending for their recovery. Overall, it's important to have a comprehensive and integrated approach in the evaluation, and it's always great to kind of be a part of or embedded within the transplant kind of team, along with working very closely with the hepatologist post-transplant. So, the insight and motivation can be variable, so I think we have to take this multifaceted approach. I think that's it. Thank you.
Thank you, Dr. Joshi. That was a comprehensive overview of the psychosocial care in our transplant candidates. We'll now keep it open for a discussion. Maybe I'll go with Dr. Maliakal, Dr. Jalal, and then and we'll take it from there. The others, please raise your hands as well if you have any other questions. Dr. Maliakal, please. Thank you so much for joining.
Thank you. That was quite a comprehensive talk. But I had a few questions, uh, in terms of alcohol. Uh, I don't see too many people using combination pharmacotherapy, like say acamprosate plus naltrexone or baclofen plus or antidepressant with naltrexone or something of that nature. I don't see too many. And then the other thing is about the GLP-1, whether that is going to have a role. That's one question. The other thing I've noticed is involvement of family and family dynamics and things of that nature matter a lot. Either the family drives people to alcoholism or the family support is very important. Most of the patients I follow post-transplant who are doing really well have had a spouse or a mother or a opposite sex person that is very involved and is willing to spend a lot of time and effort to help the patient. And those people seem to do well, if they avail their resources. There are some who, are against that and they want to be their own person and they don't do terribly well. And um, the role of social worker, I think, is probably very important as a liaison between psych and patient. And I see good social workers can develop a good relationship with the patient and the family and kind of be very helpful in keeping them sober and, on track. Yeah, I think I just wanted to mention those things and your comments on that.
Agreed. I completely agree about the social support. And yes, we value our social workers. They are, they are kind of crucial members of our team. With regard to social support, I do agree, it can either drive them to drinking and or kind of help them. So vast majority of our patients do better with, as you've noticed yourself, with presence of kind of the support because they tend to isolate more with addiction. We see this isolation and kind of hiding of their, alcohol use. There's a sense of, shame, a remorse, guilt. They no longer feel like they're valuable members of society or even for their family. So they kind of alienate themselves from family. And so when they actually go through this traumatic experience, and family is by their side or besides them, they actually, it's a sense of kind of hope for them and they tend to do much better. Also, with the chronically relapsing, remitting nature of this, it's important that family is also educated and understands the severity of what is going to come, what will happen. And more often than not, family has been the one to notify us that, hey, patient so and so has relapsed, can we bring him into the hospital? Is there anything? And it was that's kind of a little different from what was prior to the transplant, because I think family was largely unaware, and after we provide them with this education, they work very closely and kind of are, also monitoring and are, an extension of the team and helping us also navigate and deal with addiction. With regard to the medications, I know, I agree with you. Not many people use multiple agents at once. The two agents that we use in terms of medications, we use a lot of naltrexone and gabapentin. And the gabapentin, like I said, it's pretty off-label, but it's more so for that anxiety component. And multiple agents are often used if there's a comorbid psychiatric illness. And so antidepressants, obviously the alcohol use disorder treatment, like the naltrexone, is not going to address this long-standing history of maybe major depressive disorder and anxiety. And all of our antidepressants do a phenomenal job targeting anxiety as well. Unfortunately, our patients don't stay compliant on it long enough for them to kind of be effective. So when they are, they tend to do much, much better. So I do agree, and I think there is some utility to using, multiple agents if there is, any indication that they have underlying depression or, existing generalized anxiety disorder, or something that can be targeted. What I would say is probably refrain from use of, makes sense, but benzodiazepines, I think we kind of steer away from benzodiazepines, and my patients often ask for that for their anxiety. I call it freeze-dried alcohol because it works in the same way. So, but our traditional antidepressants do an amazing job kind of when adjuncted to the naltrexone and or the acamprosate.
Thank you. Just one question about buspirone. Uh, I use some of that because, many of them have anxiety and insomnia combination. And so sometimes, use that in combination with naltrexone in the morning and some anti-anxiety towards the evening or something of that nature.
Yeah, buspirone pretty efficacious. It's often it has not the greatest reputation, and just because I don't think it's dosed appropriately. But the proper way of giving buspar is multiple times a day. It has pretty like short half-life, so it needs to be administered also like in a TID fashion. But it does really well. I would say at like 30 milligrams and above. But it tends to be pretty efficacious. It just needs to be dosed pretty I think frequently, just because I think it takes, it's out of your system within like 8 hours or so. So if you can dose it multiple times a day, at least BID or TID. Once again, I know patient compliance becomes an issue in this respect, but yeah, I think there is benefit to buspar if dosed appropriately.
Thank you. I think Benedict, you also asked about the utility of GLP-1. I think there are some recent studies, preliminary or small studies that have shown benefit, but I think we need a larger trial to really show its benefit.
Thanks.
And Dr. Jalal, Dr. Jalal is on a vacation, but thanks for joining as well.
Oh, thank you. This is a very comprehensive talk. Appreciate it. Now, a practical question is, when a patient comes to the hospital with acute alcohol-associated hepatitis and they're being discharged, at your center, what kind of support you offer? I mean, we always write, follow this, that, but when they're going home, what kind of support system do you look for and what do you offer?
Sure. So, support system at home, I think social work, first and foremost, I think there's an education piece that occurs, if there is somebody at home, we would prefer to have a support system in place. So we kind of start preemptively by doing family meetings or whoever they have identified and kind of from the, I think, initial psychosocial assessment to the day of discharge, I think the family is educated about what to expect post discharge. The resources that we offer, along with our coordinator, our coordinators follow their journey post transplant. So once they have left the hospital, our social workers and our case coordinators will kind of follow up with the patient to ensure that they have enrolled in the relapse prevention program. Most of the programs that we previously used to refer to, the patient had to call themselves, and now we have preemptively already, started setting up their appointments. Once they are discharged, they go to the designated program. Once they do their intake, the providers at the program notify us and kind of we partner with them and help them out, especially if they have questions with regard to their treatment regimen, medications wise. So we kind of continue to follow their journey post discharge, and then with patients following up with their hepatologists or even surgeons, I think they let us know or they notify us if there's any concerns of the patient not complying. I think psychiatry preemptively will also join into that appointment, and so we make sure there's very close follow-up post discharge too. And so we collaborate with the community psychiatrists as well as patients tend to come to their medical appointments. They tend to show they're psychiatric. And so we've embedded it's a collaborative care model almost, having psychiatry present for these medical appointments too.
Now, the biggest challenge we always have the compliance and the insurance. So as a question to both Dr. Satpathy and you. So do you think we should have model for in-house or in a hospital system having rehabilitation program? Because a lot of time we say join the rehabilitation program, we end there, but we didn't know whether it's being covered by insurance or really they have the resources or not. So do you think there's any role for in-house or in-hospital rehabilitation program development? That's one. Second thing is, what's the typical medication you offer at discharge for relapse prevention?
Yeah, maybe I can then start, and then Nishi, you can jump in. The good news is for our program at Northwell Health is a big network of hospitals, and we have multiple hospitals that provide psychiatric care, specifically addiction psychiatry program they do have. So we kind of partnered with them within the chain of hospitals that we have, and built a transplant-specific support programs, which and do have a psychiatrist, and they do have some counselor, they do have some social worker. So they built at least 3 or 4 teams that we have within our system, and they're kind of widely distributed across the New York region. So this is a great help for our program, and the way what we're doing, which is kind of a unique approach, I will say. When we started, I don't know if it's still unique now, but what we've been doing is we're re-stratifying patients who is at high risk of relapse. I think all centers do it, but then they decline patients who is at high risk. We don't decline patients who is at high risk of relapse. Basically, we are identifying patients who is at high risk and who is potentially amenable for reduced risk or harm reduction after transplant. I think that's where our major focus is. That's where the psychiatrists kind of intersect into different levels. of potential chance that we can modify their risk profile post transplant. And this is where we are kind of finding out those who are high risk, they go into a certain intensive level of post transplant rehabilitation. Like, for example, someone who is at high risk, they may start uh, in-person outpatient program after their transplant after about a month, because first 1 month is a much more intense post-surgical care, and after 1 month they go to that kind of to reduce their risk. Or if they're not that higher risk, maybe they would go to uh, online, like a Zoom uh, meetings for their post-transplant rehabilitations. So we tried in person in the past, but it was a disaster. It didn't work out because it is so difficult to get them to inpatient rehabilitation post-transplant, because they feel good at that point and they really don't want to go. But they're more amenable to do this in person as well as uh, the Zoom meetings, and which is kind of working, at least reducing the harm. Our In our center, we have done about 300 plus transplants in the last 3 years or 4 years, and a vast majority of them alcohol use disorders, and we have about 15% relapse, right, harmful relapse. And these harmful relapse, none of them died actually because of the harmful relapse. They're all been they're potentially having rejections and all those and hospitalizations. These are relapse patients, but they're doing well from rejection, from survival point of view so far. Some of them are really doing poorly, yes, but the vast majority doing well. Nisi, if you want to add on anything.
Yeah, and to comment on the utility of having an in-house, I think that would be the ideal scenario. We've spoken about that. The only barrier, and we have also attempted in the past to get the patient preemptively enrolled in like a virtual relapse prevention program while they were inpatient. Unfortunately, it did not work out as planned. It was quite challenging as patients not cognitively intact or not able to really fully participate and benefit from that therapy. In an ideal setting, I do agree with you. I think it would help to have some form of kind of program. It's just the patient might not be able to participate. I think an alternative to that, and I think I've proposed this to Dr. Satpathy, is kind of having a psychologist be able to kind of provide psychotherapy or that kind of that motivational interviewing, that component of kind of helping them kind of navigate through these stages of change. So that would be a start, and it's not a full-on program, but I think having a component of therapy incorporated along with kind of medication management would be step one. In an ideal scenario, it'd be great to have a program in-house, and so we can just refer these patients to the programs rather than kind of go through the challenges like insurance coverage and whatnot. But I do agree. It's just we tried this remote kind of program and it didn't work out, unfortunately. But in an ideal scenario, I think that'd be nice to have.
No, that's a great answer. Yeah. We always have this, we always say that go to AA, see a psychiatrist, but literally, as Dr. Sapti mentioned it, the goal is not to exclude these people. We need to find out what's the main reason for their relapse, and we can support them. But yeah, it's always a challenge. And with alcohol being the number one cause for transplant in majority of the centers now, so I think we need to, maybe we don't have enough support like what you guys have. So this is a challenge. Our relapse rate is higher than 15% over 3 years. I can tell you that probably a quarter of them relapse. And it's post-transplant, and pre-transplant is even worse. So and what medication do you use typically on discharge?
Sorry. Yeah, so we actually, I think our first line is acamprosate or Campril. We prefer it, we've had good outcomes. Unfortunately, I think it was on a national shortage recently, but Campril is usually our first line. And then naltrexone is also another one that we use.
And patient, use it at least more or less with high MELD score patients decompensated. Our psychiatrists have a little resistance about using naltrexone in decomp patients. I don't know why, but you guys use either one in high MELD patients?
Yeah, many of the psychiatrists were also hesitant initially, but I had to pull together some of the data to show, but not Nishi. I'm not talking about Nishi. Nishi is very much in favor of using it, but there are other psychiatrists who kind of were not very reluctant to use it. But when we start together, a journal club and put together these ideas, and look, this is same, and we've been using it the last 3-4 years. So none of them has any significant side effect out of this psychiatrist so far.
With acamprosate?
Yeah.
Or naltrexone? Okay.
Both of them. But we just, as Nishi mentioned, naltrexone only caveat is you can't use it somebody post-transplant because early post-transplant at least because of the opioid use.
Of course. That's great.
Yeah. So
thank you. Yeah.
Thank you. I think we should end here. Thank you, everyone, and thank you particularly Dr. Joshi for such a wonderful lecture and a great engaging discussion as well. And with your permission, we'll put this video online, and so that people who has not been able to join today, they come back and join and listen to this talk. And any questions, I will refer to you as well. If there is an email comes to me, I'll refer to you. Thank you so much. Thank you, everyone. Have a happy New Year that's coming. Happy holidays and enjoy. Bye-bye.